Good morning. Today I am going to talk about the topic habits and malocclusion. Introduction. Habits may be a part of normal development, a symptom with a deep-rooted psychological basis, or may be as a result of abnormal growth and development. It may bring about normal function and form in an individual, or it can result in harmful unwanted changes. These are the definitions of habits given by different authors. According to Dorland in 1957, habit can be defined as a fixed or constant practice which is established by frequent repetition. Classifications. Different authors have classified habits into different names. So, according to author James in 1923, he classified habits as useful and harmful habits. Kingsley in 1958 classified habits as functional oral habits, muscular habits, combined ones. Morris and Bohanna classified habits as pressure habits, non-pressure habits, and biting habits. According to Klein, it is empty and meaningful habits. And according to Finn, it is compulsive habits, non-compulsive habits, and it is further classified as primary habits and secondary habits. Does habit cause malocclusion? So bone is considered as a plastic structure. If there is any change in the equilibrium, which will result in malocclusion. So the controversy is habits is a etiologic factor or an adaptive one. These are the three main triad of factors which contribute for habits. One is the duration, second one is the intensity, and third one is the frequency. Habits are classified as oral habits and extra-oral habits. Pressure habits. All pressures fall into one of two classifications. One is intentional and the other one is unintentional. So as early as 1903, George T. Baker attributed a case of malocclusion to a sleeping habit in which the child exerted constant pressure against the mandible. In 1920, Calvin Case explained lateral malocclusion by the pillowing habits of early infancy. Unintentional or abnormal pressure habits. Intrinsic or pressure habits within the mouth, extragenous or extrinsic abnormal pressure habits on the face, and functional pressures. Unintentional intrinsic pressure habits are sucking habits and abnormal tongue habits. So under sucking habits, we have nutritive or non-nutritive habits. Now let's move to the topic thumb and digit sucking habit. So these are the theories which contribute to digit sucking. First one is classical Freudian theory given in 1905, the learning theory by Davidson in 1967, oral drive theory by Sears and Weiss in 1982, Johnson and Larson theory in 1993, Benjamin's theory in 1962. Classification by Subtanley in 1973 is mainly based on type A and type B. So type A means this type is seen in almost 50% of the children, wherein whole digit is placed inside the mouth with a pair of the thumb pressing against the palate, while at the same time the maxillary and the mandibular anteriors will be in contact. Type B, this type is seen in almost 13 to 14% of the children, wherein the thumb is placed in the oral cavity without touching the vault of the palate, while at the same time the maxillary and mandibular anteriors contact is maintained. Type C, this type is seen in 18% of the children where the thumb is placed into the mouth just beyond the first joint and contacts the hard palate and only the maxillary incisors, but there is no contact with the mandibular incisors. Type D, this type is seen in almost 6% of the children where a very little portion of the thumb will be placed onto the mouth. Now let's move to diagnosis. So under diagnosis part we have history, then extraoral examination, intraoral examination. So under extraoral examination we have to check the digits, lips, facial form and other features. Intraoral examination we have to check the tongue, dentoalveolar structures and the gingiva. So these are the clinical features of a patient presenting with a thumb sucking or digit sucking habit. The first one is anterior open bite. Second one is a posterior crossbite. So studies have registered an increased prevalence of posterior crossbite in patients with the thumb sucking habit. Next, what is the effect of thumb sucking on maxilla? So there will be increased proclination of the maxillary incisors, increased anterior placement of apical base, increased SNA angle, increased clinical crown length of anteriors, increased counterclockwise rotation of occlusal plane, decreased palatal arch width, increased atypical root resorption in primary central incisors, increased trauma to maxillary central incisors. Now, moving on to the effect on mandible, there is increased proclination of the mandibular incisors, increased intermolar distance, increased distal position of point B. Effect on the inter-arch relationship is decreased maxillary and mandibular incisal angle, increased overjet, decreased overbite, increased posterior crossbite, increased uni or bilateral class 2 occlusion. Next, moving on to the effect on the lip placement and the function. There will be increased lip incompetency, increased lower lip function under the maxillary incisors. Tongue effect. There will be increased tongue thrust because of the thumb sucking habit. Because of developing anterior open bite in patients, there is chance for developing tongue thrusting habits. There will be increased lip to tongue resting position, increased lower tongue position. Other effect is there will be thumb deformity and increased speech defect, mainly lisping. Corrective measures. There are three methods to correct the thumb sucking habit. First is by behavioral management, second is mechanotherapy, and third is by the chemical approach. Behavioral management was proposed by Erickson. So he relies on the psychological principle of reframing. That is the beta hypothesis by Dunlap. Next is mechanical aids. These are the various mechanical aids which we can use for correcting thumb sucking habits. One is crib, the other one is rates. Then we can go for the combo appliance. Then there is TLC, that is triple loop corrector, and also we can provide thumb guards. Chemical approaches, pepper dissolved in a volatile medium. We can give quinine or asafoetida. We can apply it on the thumb, and when the patient suck that, it will produce a bitter feeling. So that will result in refraining from the habits. Thank you.